So the involvement of the dietitian, of course, is in nutrition and hydration, and this might seem a little bit odd, and thinking that nutrition is not as important in someone who is dying, but nutritional intake is both clinical and quality of life issue. So a holistic approach is required, considering the physiological, social, cultural needs of the patient, their personal taste preferences and so forth. Common issues related to nutrition are weight loss, particularly in those patients diagnosed with cancer. They tend to lose significant amounts of weight during the palliative stages. They develop protein energy malnutrition, depression, fatigue, delirium, other issues that can be associated are advanced dementia, paranoid behaviour, apathy, and, as I said, fatigue. With all this going on, it may still be appropriate to offer small amounts of food and fluids, even if and when the person is dying. They might only have days to live, but we need comfort measures as well for these patients, and the dietitian is very much involved in this type of decision making. Of course, texture modified foods and fluids are often implemented. This can occur in consultation with both the dietitian and the speech pathologist, who will manage the swallowing of the patient. There may well be swallowing difficulties or dysphagia, and decisions need to be made around the thickness and the texture of the food, to avoid the risk of to the patient for choking and aspiration. But having said this, need to take into account how much longer the person has to live and their quality of life and their enjoyment of their last days. If the quality of life is more important than the risk, then decisions have to be made around that. A lot of patients don't enjoy the changes in texture modification, so that needs to be considered too. And the multidisciplinary team will discuss and make decisions around this, including the dietitian, as I've mentioned. Advanced dementia can be involved with these patients. They can refuse food, and while we have to take into account the personal preference of the patient, we need to consider whether ceasing eating is in line with their overall deterioration. Is it due to a treatable condition that is affecting their cognitive decision making and appetite? Do they have infection? Do they have oral health factors preventing them from wanting to eat? Are they on a therapeutic diet that's inappropriate now, low fat, low salt, which may have been appropriate before they became palliative, but now is causing them to have a limited choice of foods, and perhaps lacking in the vitamins and minerals that they need. As I said, it may be still appropriate to offer small amounts of foods and fluids in these cases as well, and to consider options for treating the patient and what are the underlying factors. So the dietitian is involved in mouth care. This is essential even when a patient is no longer taking food or fluids. Dentition, ill-fitting dentures, for example, will cause pain and chewing difficulties. The patient might start to refuse food and need to consider the dentition there. Artificial and hydration and nutrition can be provided through IV or oral tube feeding, and what is the best route of feeding is a decision that's usually made by the multidisciplinary team. Enteral nutrition or parenteral nutrition may not be the most appropriate form of nutrition support for a patient who's palliative or dying. Consent for withdrawal of artificial nutrition in palliative patients is required. Palliative terminal patients may also be excluded from being weighed during this time. So lots of things to consider, and I just want to acknowledge Claire Barrett, who's an accredited practicing dietitian and director of